Thank you all for joining us today, and especially thank you to our partner in today's Lunch and Learn Primary Health Network and Dr. Garrow. Today we are talking with Dr. Garrow. He's the Chief Medical Officer at Primary Health Network, which he has served there since March of 2016. During the global pandemic, Dr. Garrow has worked diligently to help address the clinical and social needs of patients and communities served by Primary Health Network. And he remains focused on overcoming health disparities, which have led to a disproportionate impact of the disease among risk among groups in our community. So Dr. Garrow, thank you so much for joining us today. We're looking forward to hearing what you have to share with COVID or dealing with COVID with us today. Dr. Garrow is also a board member of the Buell Regional Health Foundation. So thank you.
Thank you, Donna. Thanks, everyone. Thanks for taking some time out on Fat Tuesday to spend some time with me. You know, it'll soon be 2 years since the World Health Organization designated COVID-19 as a global pandemic. And I don't know about you, but it feels like it's been a long, hard 2 years. I never, ever in my career expected to be working under the conditions of a global pandemic. But, you know, as I reflect back on the journey that we have collectively been on as a community since that time in March of 2020, number one, I'm just so grateful for the support of all of you. I know that I've had the opportunity to work with many of you on occasions over the last couple of years. Particularly grateful for the support of my friends at the Buell Regional Health Foundation. You know, our community is really so fortunate to have the resources that the Buell Regional Health Foundation brings. I talk to colleagues and coworkers, colleagues of mine that are in similar positions in other communities and that don't necessarily have the access to the resources like we do from the Health Foundation. So Kateri, Jen, Kimberly, Donna, everyone, Jess from the Buell Regional Health Foundation, thank you so much, for all that you've done to work hard to keep our community safe. So, feels like things are a little different now, maybe than they were in January, right? It seems like some of the pressure seems to be lessening a little bit, for which I am extremely grateful. But you know what? It's important to remember that it's not over yet. It may look a little different now. Fortunately, it seems that our cases are diminishing, and the strain that the pandemic is placing on our healthcare systems and our first responders and in our community seems to be backing off a little bit. And I think we can all collectively give a shout that, yeah, that's a good thing. It does seem to be lessening, but it's important to remember that it's not over. And we still need to be diligent to protect one another, particularly the most vulnerable in our communities. So want to begin by just sort of going back to the basics, if you will. I have used the term Public Health 101, just the basic fundamentals, the blocking and tackling, if you will, of how to protect one another during a contagion, such as COVID-19 or other potentially transmissible illnesses. Infection control has never been more important. It's still really important to wash your hands and to try to maintain safe social distance when possible. We're getting a lot of mixed messages about masking, right? Do you wear a mask? Do you not wear a mask? What kind of mask do you need to wear? Many jurisdictions have backed down on their masking requirements in public places. I tell my team here at Primary Health Network, and I'm sure others of you who work in healthcare, that the mask requirements are still necessary in healthcare settings. Why? Why do we have to wear a mask in a healthcare setting? Well, that's where vulnerable patients come to get care. individuals who may be immunocompromised or, would be at greater risk for developing complications if they were to acquire the virus. So here at PHN, when I'm not in my office by myself, I have to wear my mask when I go down the hallway to the copy machine or when I go into the clinic area or ride the elevator and I'm in common areas. Recently, the CDC kind of said, okay, well, here's what we know about masking and when you should wear a mask and not. And they really broke it down by what is the prevalence of COVID in your community. And they broke it down into three categories: a low prevalence rate, a low concern rate, a green category, if you will, a medium prevalence rate, sort of in the yellow, and then a high prevalence rate in a red, right? Red, yellow, green, right? Stop, slow down, go. So in individuals who live and work in a low prevalence community, the recommendations are that you stay up to date with your COVID vaccine, and we'll talk a little bit about what that means, and to get tested if you have symptoms. In the medium category, the medium prevalence rate, yellow, which is where we are in Mercer County, that we encourage individuals who may be at risk if they were to develop COVID, if they were to acquire COVID, if they are at risk for developing complications, severe illness, the need to go to the hospital, that they should talk to their primary care provider or their healthcare providers about what level of public health response they should take. Should they wear a mask or not? And obviously to stay up to date on their vaccines and to get tested if they have symptoms. There are still some communities in our country and in our state that are considered high and are in that red category. And in those communities, individuals should still wear a mask when they're indoors in the public around others, because the rate of transmission is relatively high. And additional precautions should be taken for those individuals who are at greatest risk. So the CDC last week kind of shifted to this community-based approach to wearing a mask and other precautions. And the good news is that Mercer County, Lawrence County are in that medium zone. So it's possible that we can be comfortable and go to the grocery store and be around others, being mindful that we still want to wash our hands and maintain our social distance. I've chosen to continue to wear my mask when I go to the grocery store because I'm concerned about the other people that are there shopping. I don't know which of those people might be immunocompromised or might be at greatest risk. So I've made the conscious decision to continue to wear my mask when I'm outdoors in public spaces, because I really want to go the extra mile to protect others who are most vulnerable. It may not be mandated in the stores or in public spaces, but I encourage you to make a decision that you are most comfortable with. Now, I've had a lot of folks ask about, well, what mask is a good mask, right? And we're getting a lot of stories about masks and what you should wear and you shouldn't wear. Well, the best mask is the mask that fits best and that is worn correctly. The best masks, when we look at data to talk about, preventing or eliminating the transmission of a particle the size of the coronavirus, N95 and KN95 masks by far are the best, as long as they're worn correctly, cover the nose and the mouth, and have a tight fit. A poorly fitting N95 or KN95 is obviously not as good as a well-fitting KN95 or N95. And those masks that are well fit can eliminate the spread of a particle the size of coronavirus. 80 to 95% of those particles can be prevented from transmission. Interestingly, a woven nylon mask with a aluminum nose bridge and a filter cuts out about 75% transmission of the particles. And a surgical mask with a tie cuts out about 72%. This mask, which is a medical surgical mask with ear loops and the corners tucked under my chin, cut out about 60%. And a woven nylon mask without an aluminum bridge cuts out about 56% of the particles being spread. So even wearing a nylon woven mask without an aluminum nose bridge cuts out more than half of the viral particles that can be transmitted. Now, because I'm particularly fashionable, I have a whole drawer full of cloth masks that actually match my bow tie. So now I look at that drawer of my cloth masks and I think, are they useful at all? Is that just a fashion statement or do they do anything? Well, you know what they do. A double layer cloth mask that's well fit and ties behind the neck and the head cuts out about 40% of the viral particles being transmitted. So wearing one of those fashionable cloth masks that mask my tie cuts out less than half of the viral particles that I might be transmitting. So it's better than nothing, but it's not something to rely on, particularly if I'm going to be around individuals who are immunocompromised. So again, the best mask is the mask that you wear correctly, covering the nose and the mouth, and that's well fit. An N95 cuts out the greatest amount, but even a nylon woven mask with an aluminum bridge cuts out 3/4 of the viral particles. So that's my story about masks. And those cloth masks that I have, they're kind of staying in the drawer for right now. So I'm not wearing them out too awful much any longer. So what about testing? There are several different types of tests that can be done. And the one test I want to talk about, just to kind of get it out of the way, is the antibody test. So antibodies are proteins that we make in response to an infection. They're proteins manufactured by white blood cells in our body called B cells. And we can actually measure antibodies to various things. And we can measure antibodies to coronavirus. We don't really know what level of antibody you need in the blood test to know that you're immune. Really, the role for an antibody test is just to tell you whether or not you've been exposed potentially to COVID, but it really is not something that's needed or useful on a clinical basis to let you know whether you're safe to go back to work or if you need to get a vaccine or not. It doesn't mean anything in that regard at all. There's very little role clinically for an antibody test. Now, looking for the presence of the virus, there's actually a couple of different tests. One is one that we call a NAA, a nuclear amino acid test, NAA test, that's run by PCR, polymerase chain reaction. And this is a very, very sensitive test that's collected using a nasal or a nasopharyngeal swab. You might sometimes hear people talk about these tests as being a send out. They're collected and we send them to the lab. And right now we're getting them back in usually about 24 hours, sometimes 36 hours. So the turnaround time for these PCR tests is a lot better, very sensitive. If you have a positive PCR test, you have COVID. Now, the test is really sensitive. So you could have had COVID a week ago and you may not be contagious, but you may still test positive on the PCR test. So that's important that if your employer says, I need a negative test before you come back to work, and you have a positive PCR test, it doesn't necessarily mean that you're contagious, but there are remnants of the virus that are still present that test is able to pick up. But if you're positive on a PCR with symptoms and you're early in, you likely have COVID. The likelihood of false positive tests with a PCR test is pretty remote. The likelihood of a false negative on the PCR test is not insignificant. It's running now at about maybe 10 to 10% maybe. So what we say to individuals is, if you have symptoms and you have a PCR test and it's negative, you may want to still hunker down and isolate and maybe get tested a second time just to make sure it wasn't a false negative, right? And then there are these rapid tests or an antigen test, which basically just kind of looks for the whole virus itself, right? And these are the home test kits that we've been giving out and that are now more readily available. The positive news about these rapid tests is you get your results back relatively quickly, right? You could test at home and look at the result and you probably get your results back in about 15 minutes. If you're symptomatic and you have a positive home test, you likely have COVID. A true positive, or let me say this, a false positive on the rapid test is pretty small. So if you're symptomatic and you test positive on a home test, you need to listen to that and you need to isolate as recommended. However, if you're symptomatic and you do a home test and you're negative, there's a higher likelihood of it being falsely negative. And you still probably need to hunker down and repeat the test again 24 hours later to make sure. Even on the second test, if it's negative and you're still having symptoms and you're worried that it could be COVID, you probably ought to get a PCR test because it's a lot more sensitive. So my wife applied to get the federal test kits at home. They came the other day. So they're sitting on my dining room table. And we had this discussion last night. Okay, when do we use these tests, right? Well, you don't want to use them just because. You don't want to use them if you're, having people come over on Friday and you just want to, hey, are you positive or not? No, that's probably not the role for these tests. I would recommend reserving the home test kits for a time that you may be symptomatic, or if you've been exposed to someone who has tested positive for COVID. So you want to know if you have it now that you were in close contact, or if you're going to be around someone who's potentially immunocompromised or it might be at risk for developing COVID, it might be a good idea to do that COVID test. You're not symptomatic, but you just want to know, can I give it to this person who, might be immunocompromised? Because if I'm positive, I'm going to stay home. I think those would be the three scenarios where I would recommend using the home tests. So you're symptomatic and you want to know if you have COVID. And as I said, if it's negative, you still want to be diligent. Or two, you've been exposed to someone who is positive and you want to know if you have it. And we usually recommend you test maybe 3 days later after your exposure. Or if you're going to go visit someone, be in close proximity to someone who's immunocompromised, and you want to know maybe you're an asymptomatic carrier and you don't want to give it to that person. That, in my mind, is the role for those home antigen tests. Okay? All right. Next, I want to talk about vaccines. I see my friend Tracy's on the call. So Tracy, please chime in and make sure we're answering folks' questions correctly. So the vaccines remain our single best tool to try to help get us through this and get it behind us, right? And so there are plenty of vaccines readily available. Currently, we are really encouraging the use of the mRNA vaccines. That would be the Moderna or the Pfizer product. And now individuals from the age of 5 up to 105 or beyond are eligible to get one of the COVID vaccines. Pfizer has vaccines for children ages 5 to 11, and then for adolescents and adult ages 12 and up. Moderna has a vaccine that's now available for adults 18 and older. We're still waiting for the FDA to give emergency use authorization for Moderna vaccine for adolescents down to the age of 12. The FDA has the data. They're continuing to look at it. I think I take that as a really good sign, because that means they really want to make sure that it's safe before they give the emergency use authorization for it. I've seen the data. The Moderna vaccine looks really very good, very safe, and very effective. But I think the FDA is doing their job. They're keeping us healthy and safe. There are clinical trials currently underway looking at the Moderna down to the age of 5. And as I'm sure you recently heard, the FDA considered a vaccine from Pfizer for children from the ages of 6 months of age to 4 years of age. And you know what? They did the right thing. They said, yeah, we need a little more data here before we let this out. We just want to make sure it's safe for those kids. So in my mind, that tells me the process is really working well, exactly the way it was designed to work. That's great. So when are you up to date? What does that fully vaccinated mean? Well, we are now kind of using the term up to date on vaccines. And again, we encourage everybody to get their primary series of the vaccines. And most individuals are now eligible to get a booster 5 months after they complete their primary series. The only exception to that is individuals who are immunocompromised, and they can get their booster dose, if you will, 3 months after they complete their primary series. And some individuals can actually get a third dose, right, even a month after they as part of their primary series, and then get their booster dose, which would basically be their 4th dose 3 months later. And so we've actually been giving. I've been giving people here, we're here today, and they actually got their 4th dose. They got 3 doses as part of their primary series, and then they got a booster dose now 3 months later because they're immunocompromised. And what about the rest of us? Are we apt to get a 4th dose if we've had our booster? Are we apt to get a 4th dose? Yeah, maybe. We'll see. They're actually looking at it really closely and carefully. It's possible that we may see that this immunity after the booster doses falls down, and we may need another dose maybe in the fall. Sort of like we get flu shots every fall, we may want to look at getting doses for COVID annually or more frequently based upon what the data is showing. Now, when I finally put my head on the pillow at night at the end of a day and I close my eyes, I rest comfortably knowing that there are really, really, really smart people, epidemiologists, infectious disease doctors, public disease folks that are carefully analyzing the data. And as soon as they know whether a 4th dose or another dose is necessary, we'll know. And Donna, and as soon as I know, I'll let you know so that we could do this again and keep people up to date. I promise. And then in the few minutes left before I quit talking and answer questions, I just want to mention some really exciting new developments regarding therapeutics for COVID infections. Gosh, this is just absolutely amazing. If I think back to where we were a year ago, to where we are now, and we have tools in our toolbox to try to help individuals who are positive for COVID that we didn't have a year ago, it's amazing. Life is really, truly good. And our scientists and the smart researchers have really done a great job positioning us so that we have tools that we didn't have available, a year or so ago. There are currently monoclonal antibody infusions that we can give to individuals who test positive for COVID and are at risk for developing complications. The one in particular that is now available is called sotrovimab. There's another one that has recently received emergency use authorization. And these are typically reserved for individuals who have tested positive for COVID-19 and have risk factors that say they might be more apt to go to the hospital, end up in the intensive care unit, or have complications, right? And so what we encourage, if you know of anyone who's tested positive for COVID and they think that they might benefit from one of these monoclonal antibody treatments, that they should talk to their PCP or reach out to me, and I'd be happy to kind of assess their risk and determine whether or not they're a candidate to get one of these monoclonal antibody treatments. There are now oral antivirals too that have received emergency use for outpatient use. One is called Paxlovid. It's a pills. And the second is called molnupiravir. I'll ask Tom to spell that later, molnupiravir. And both of these medicines have been given emergency use authorization by the FDA, again, for individuals who test positive for COVID and are at risk for developing severe illness or hospitalization. The monoclonal antibodies are typically given as an injection or an infusion, and these oral drugs are given orally, pills. And then finally, this is really amazing. We actually have another monoclonal antibody called Evusheld, which we can give to individuals who are not infected with COVID, are not positive for COVID, but they're in that group of individuals that are immunocompromised, severely immunocompromised. My patients that are on chemotherapy, or other individuals that have had a bone marrow transplant or organ transplant, other immunodeficiency conditions, they can actually receive injections of an antibody that will give them added protection. So that if they were to come down with COVID, their risk would be diminished. Now, the Evusheld does not replace vaccine, but it's an additional layer to try to protect those vulnerable individuals. So again, if you or anyone that you know of is in that category, that they're significantly immunocompromised, encourage them to reach out to their PCP or to contact me or the state health department or the CDC, and we'd be happy to try to navigate them to have their questions answered regarding any of these potential COVID therapeutics. So it's amazing how far we've come in a year. It was a year ago this past weekend, Tracy, Jennifer, you remember? It was my birthday last year, and we had a mass vaccination clinic here in Mercer County at the Buell Club. And it was the greatest birthday present a guy could have ever asked for. That our team, our community pulled together, and we worked hard to identify individuals in our community who maybe were having challenges accessing the COVID vaccines. It was a wonderful day, and I look back on it with such nostalgia and gratitude that we pulled together as a community. And I'm looking forward to continued successes as we work collectively as a community. I see that we have really united in our effort to try to make sure that not only are we addressing COVID amongst ourselves, but have an eye out for those in our community who may be more vulnerable or disenfranchised or maybe have struggles with access. So with all of that, surprisingly, I'm going to quit talking and see what questions you guys might have.
Dr. Garrow, would you mind talking? Oh, sorry, Kateri, I didn't see you had your hand up. Go ahead.
No, I have questions. So if you want to keep going on topics,
let's stop and go ahead and have Dr. Garrow turn off the recording, unless anybody wants to ask.
I just wondered if Dr. Garrow might address long haulers before we turn off the recording.
Oh, yeah, thank you, Jennifer. Yeah, that was on my list. I neglected to mention it. Okay, so my New Year's resolution for 2022 is that I decided I really want to learn as much as I possibly can about long-term complications after individuals have recovered from COVID. And it has a number of different terms or names for, long haul syndrome, long COVID syndrome, post-acute syndrome of COVID, PASC. That's sort of the medical term for it, post-acute syndrome following COVID. And I really would like to reassure anyone who feels that they might be suffering from lingering side effects, complications after recovery from COVID. You know what? It's real, right? You're not making it up. I believe you. And I know the medical community recognizes it now. And it can take on a myriad of symptoms and conditions, from chronic fatigue, from shortness of breath, foggy brain, all the way up to longer term complications of POTS syndrome, orthostatic changes in blood pressure, so that folks can't stand up, they get dizzy, effects on other organs, the lungs, the liver, the kidney, the brains. It's real. What I would encourage anyone who feels that they might have lingering symptoms after recovery from COVID to continue to work with their PCP. Referral to specialists maybe isn't always helpful because sometimes the specialists don't really know what to do. The good news is that I think over the coming year, that we in the medical community are going to be able to better understand what some of these long-term symptoms, lingering symptoms after COVID, how they occur, and what we can do to manage it. Be patient with us. We're learning. I'm learning. I'm learning, a ton about all of this, but it's real. And I just wanted to validate that, we're going to work to help you understand it and how we can help to get you better. All right. Any other before we turn off the recording and then unleash the questions?